his background is immunology, but he was smartly recruited to Washington University in St. Louis, which has a fabulous itch center. So he now thinks neuro a lot. And the other thing is, he got married about 5 weeks ago, and it's wonderful that he's here and not still on a honeymoon. Brian.
Thank you, Ethan, for the introduction. Thanks to the organizers for inviting me to speak here today. I'll start by just talking about recent work we've done, and what I'll focus a little bit more on today is putting this work into the context of the work of others, a lot of clinical findings, and also speak to emerging clinical trials and how this work actually specifically plugs into what we're now seeing in the clinical trial space with regard to atopic dermatitis and itch. I have a number of disclosures. Personally, I think they're all relevant because they're all subsequent to the work that I'm going to be showing here today. I also have a patent application for the use of JAK inhibitors actually for itch, which will also be discussed in this talk. So Serena spoke about atopic dermatitis, and she explained this quite well. This is a disease in which we've been really exploring this as a model paradigm in which to study both inflammation and itch. And we've always been interested in understanding how inflammation leads to rash in the skin. And more recently, we focused our attention on understanding how inflammation leads to the sensation of itch, which Serena was referring to quite a bit. Importantly, in this disorder, itch is the central and hallmark symptom. So when we actually first embarked on these studies, when we were trying to understand how inflammation leads to the rash, we were focused, the paradigm was that T cells were really at the center of this universe. And then the idea was that the Th2 cell, marked by the production of the Th2 cell-associated cytokines, IL-4, 5, and 13, results in damage to the epithelial barrier, but also the underlying immune dysfunction we know of in atopic dermatitis, as an example, elevation of IgE. But with the discovery of the epithelial cell-derived cytokines, particularly IL-25, IL-33, and TSLP, it was known that these cytokines are actually leaked from damaged epithelia and can broadly activate this pathway. When we started to look more deeply at this, what we found was that, in fact, not only T cells, but other innate cell populations, such as basophils in circulation, get recruited in response to these cytokines, and also previously unrecognized innate lymphoid cells, ILC2s, group 2 innate lymphoid cells, are actually dominant sources of these type 2 cytokines. So in the interest of time, I won't show any of this data as it's been actually published for a while now, but these are all papers showing the identification of these, particularly these ILC2s and their contributions to atopic dermatitis. But what this work actually allowed us to do was really lay the foundation for understanding how not only inflammation arises, but also itch. And as we know, blocking these effector cytokines like IL-4 and IL-13, especially with the advent of dupilumab, has proven to be highly efficacious in the setting of atopic dermatitis. But also during the clinical trials and subsequent to the delivery of this drug into the market, people have come to appreciate that itch is something that improves quite dramatically. And this was something that we were very interested in. So we actually took a step back and thought about how itch could actually be impacted in this disease more specifically. So how does inflammation in this setting actually lead to itch? We know that histamine can bind a histamine receptor on peripheral sensory neurons and activate these neurons to fire, and this actually can evoke symptoms of itch. We also know that non-histaminergic pathways, such as the MRGPRA3 receptor, which my colleague in the Itch Center, Chin Liu, characterized, is responsive to the compound chloroquine. Its endogenous ligands are being identified, but is a very important itch sensory receptor as well in the periphery. Further, if we go into the cytokine space, we know that cytokines such as IL-31, as well as TSLP, can actually also bind the sensory nervous system and modulate the itch sensation. And we now know that IL-31 antagonism is actually emerging as a potential therapeutic strategy for atopic itch as well. So taking a note from these studies and really putting this all together, we were very interested in understanding how, with the discovery of these innate cell populations and their contributions to atopic dermatitis, whether simply these effector type 2 cytokines could directly somehow modulate itch. So to test this, we actually looked directly on sensory neurons. We extracted dorsal root ganglia from both mice and humans. And what we found was a very striking pattern, which is that IL-4 receptor alpha is certainly expressed, but we routinely could not detect IL-5 receptor, and we could also, in fact, detect the native IL-13 receptor. As you would expect, based on what I've told you, we could certainly reliably detect the IL-31 receptor as well. And we could find this that this was very much conserved between both mice and humans. And provoking the notion that perhaps these sensory neurons could actually directly respond to cytokine, particularly to type 2 cytokines. And indeed, if we actually perform calcium imaging, we can actually extract DRG and place these into the Petri dish and actually measure calcium responses, shown as spikes here, in response to IL-4 over time. As well, as with our expression data, we see that this is a highly conserved between both mouse and human as well. So then we actually took this in vivo. So we actually wanted to see how does neuronal signaling of IL-4 actually affect itch. To do this, we actually used a well-established mouse model, which we have employed many times over, in which mice are treated with topical calcipotriol, or MC903, which is an irritant and quite readily induces AD-like disease. Notably, this is actually used to treat psoriasis, and we think perhaps this is one mechanism by which MC903 works. It antagonizes the Th17 pathway, but certainly promotes the Th2 pathway. When we go into this mouse model and we actually transcriptionally profile the skin, we find that it mirrors what we know about human atopic dermatitis. We see upregulation of the epithelial cell-derived cytokines, the type 2 cytokines. We see downregulation of filaggrin. We see it really does transcriptionally mirror what we see. But the point here being is that there are potentially a number of pruritogens or itch-inducing factors that are highly upregulated in this setting. And this is indeed associated with the development of itch in vivo, as you could see on the right. And someone was asking about, is there any kind of rewiring of the nervous system, perhaps, in the setting of chronic inflammation? So if we actually now induce AD-like disease in the mice, and we extract out the DRG, we now actually see upregulation of these receptors, a variety of potential itch-regulating receptors, indicating that perhaps there's actually a durable rewiring of the nervous system as well. One can imagine if this remains permanent, this would actually be potentially very problematic. Furthermore, if we actually intravitally, so while the mouse is alive, image these IL-4 expressing cells, what we actually were able to do is generate mice in which the peripheral neurons fluoresce red, the IL-4 expressing cells actually fluoresce green, and we can now look in the control ear and we find very little in the way of IL-4 expressing cells. But when we induce inflammation in the treated ear skin, what we find is an influx of green IL-4 expressing cells, and these cells in fact interact with the sensory nerves. And what we found is that this was not simply a stochastic random movement of these cells intravitally, but rather when we characterize this, we find that these cells actually, once they move in rather quickly, as you can see on the left, and once they interact with the nerve, if we track these cells, they seem to actually stick to the nerve, and once they release from the nerve, they move away quite rapidly, indicating that these interactions may actually be rather specific. And if you look on the right, what we find is that the nerve-associated cells actually move at a lower mean speed than the non-nerve-associated cells in this environment. So currently we're characterizing what are the molecular factors actually that regulate this kind of process. But the really million-dollar question for us is if we actually delete the receptor on the nerve, can we impact the disease in vivo? So we actually generated mice in which IL-4 receptor alpha is deleted specifically in the peripheral sensory nerves. We subjected these mice to AD-like disease, and in fact what we found was that itch was quite dramatically reduced, as shown on the left. And in association with this, we saw a reduction in the disease severity measured by both ear thickness as well as histologic parameters. In the interest of time, I won't talk about this. Also, much of this data is now published. And essentially what we found was that IL-4 is not really a pruritogen. It doesn't really induce itch, but what it does is it really modifies the sensory nervous system response to all these other pruritogens that are upregulated in the highly inflamed skin. And we think that this may actually inform therapy. This may actually make us think differently about how IL-4 receptor alpha antagonism works. Sure, it's anti-inflammatory, but actually it may be neuromodulatory as well. At the time we were doing these studies, though, dupilumab was not out. This was not really a therapeutic option. And we were actually thinking, okay, how else can we approach this? Well, we know that IL-4 receptor has to signal through the JAK signaling pathway. So we actually looked, showing on the right, on previously published single-cell RNA-seq data sets. And what we in fact found was that proreceptive neurons at the single-cell level actually seem to very much express JAK1. We could not detect JAK2, the other JAKs. That's not to say they're not expressed, because the sequencing depth at the single-cell level is often limited, but we could certainly readily detect JAK1. So, as you would expect, we actually deleted JAK1, specifically in the sensory neurons, subjected these mice to AD-like disease. In this experiment, we actually took a very different approach. We actually looked much earlier, before we knew that there would be a big divergence in disease. And what we in fact found was there was a reduction in the itch, as shown on the left, even when there was no reduction in the inflammation. What I'd like to point out here is that the kind of central dogma in the treatment of atopic dermatitis is that you have to treat the inflammation to get rid of the itch. But what we're showing here is that at the molecular level, with just deleting one gene, we can actually reduce the itch even in face of inflammation. So what I'd like to propose, and what I'd like to say even a little bit more provocatively, is that we know that the JAK inhibitors are anti-inflammatory, but what we're finding in our hands is that we think that the JAK inhibitors are actually much more neuromodulatory in the setting of itch. So we actually wanted to really test this, and to test this we actually went into another disease. This is actually what I see mostly in my clinic. We have a specialty itch clinic. We see chronic idiopathic pruritus. These patients present with really no specific cause for their itch. They don't have rash. They have no universally effective treatments. They're highly refractory to anti-inflammatory therapies, and they have severe chronic itch, at least in our clinic, on average, higher than those with moderate to severe atopic dermatitis, as shown on the right. This is what these patients look like. This is the patient on the right, in contrast to the patient on the left with lesional atopic dermatitis skin. And in fact, if we actually treat these patients with JAK inhibitors or Jakinibs, specifically tofacitinib here, what we find is that these patients respond quite robustly. We find on the left is the numerical rating scale itch score pre-treatment, showing that these patients are quite severe, and then on the right you see their response. And in fact, even if patients are treated with cyclosporin, just out of sheer desperation to get rid of whatever inflammation there is, we find that even if they don't respond, if we switch them over to the JAK inhibitor, that the response is quite remarkable. We've actually subsequently treated a number of more patients with this, and we're continuing to see this kind of result. So what we're doing now is that we're actually exploring new ways to actually employ these Jakinibs. What we can now do is actually induce, as a model, we use AD-like disease as a model of itch, and when we do this, we can actually leave the mice to develop their disease with no treatment with the JAK inhibitor whatsoever. Then one day, or 12 to 24 hours prior to measuring their itch, we can deliver a low dose of, as an example here, ruxolitinib, a JAK inhibitor, intrathecally, and then one day later measure their itch. As you would expect, there's no effect on peripheral skin inflammation as this drug is delivered intrathecally. But when we actually do take this approach, we actually see a marked reduction in itch, even with just one delivery intrathecally a day before. Furthermore, this is yet another approach we've been taking. We actually subject these mice to AD-like disease, and 24 hours before we measure itch, when these mice have never seen a JAK inhibitor, we actually gave the JAK1 selective inhibitor, itacitinib, intranasally to deliver this into the nervous system. And in fact, when we do this, we also see a very dramatic reduction in itch as well. So what does this all mean? What's the implication of this? Well, as an example, AbbVie has a JAK inhibitor that's currently in development. And when you actually see what's coming off with these trials, we're starting to see what we see actually in mice as well. Here we have a JAK inhibitor, upregulation, which demonstrated reduction in pruritus or itch within the first week, while there was improvement in skin inflammation at 2 weeks. And this is a common theme. We're seeing that these JAK inhibitors have a itch effect prior to even any effect on the inflammation. We also see that with topical JAK inhibitors, the effect on itch is happening as early as 24 hours. And this has been shown a couple of times already. To really highlight this point, if you actually look on the purple dotted line, if you compare the topical JAK inhibitor to tacrolimus, which is the anti-inflammatory agent, we see that it takes up to about a week to really see a difference in terms of the change in itch severity. While at appropriate doses of the topical JAK inhibitor, shown in the blue, yellow, and red lines, we see a reduction in itch as early as 1 day after treatment. So this was actually, this actually could have been somewhat predicted. This is a work by Yasuda et al. Actually, I think Kenji Kawashima is in the front row as I was part of this work. They actually had mice that actually had gain-of-function mutations in JAK1, and these mice developed pruritic dermatitis. And interestingly, even if when they transferred in bone marrow, that was actually normal or wild type into these mice, they could actually not rescue this phenotype. And conversely, when they actually transferred in JAK1 gain-of-function mutation bone marrow into wild-type mice, they could not recapitulate this pruritic dermatitis, already indicating that there's maybe some stromal component driving this process. We suspect that perhaps there's a neural JAK1 activation that's driving this. How about patients? Well, the first JAK1 gain-of-function, germline gain-of-function mutation patients were just discovered. These patients also have severe pruritic dermatitis. Subsequent to our work, actually, the PI contacted me and said that these children actually have very severe itch, and they cannot sleep, and they do not respond to prednisone. It was only with the discovery of the JAK1 gain-of-function mutation that they received ruxolitinib and were able to actually start sleeping. So essentially, it seems that these phenomena that we're actually observing in mice are quite predictive of what may actually be happening in patients, both with therapies as well as genetic diseases. What I'd like to highlight is by understanding the pathogenesis of disease through understanding these epithelial cell-derived cytokines, these novel innate cell populations, their effector cytokines, and identifying novel functions on neurons, we've actually been able to really inform what's really going on in the clinical space. Furthermore, I'd like to suggest that in conditions like chronic idiopathic pruritus, even in the absence of robust inflammation, this itch may still commence. I want to be a little bit more provocative and even say that perhaps there may be inflammation autonomous events occurring in the nervous system where the nervous system is simply turned on and it's really hard to shut down. And we really have to take neuromodulatory approaches to actually treat itch in this setting. So I'd like to just end by saying that we really started with one disease, that was atopic dermatitis, back in about 2009, 2008. And we've really been able to broaden our understanding not only of this disease, but genetic diseases. This has really afforded an opportunity to identify new both molecular targets as well as the identification of new cell populations, both in the immune system as well as the nervous system. And furthermore, as many of you are aware, there are a number of therapeutics targeting these pathways that are emerging, and this has implications not just for atopic dermatitis, I'd like to underscore, but a number of diseases, both in dermatology as well as beyond, that affect a lot of our neighboring specialties. Lastly, I'd like to thank members of my lab. Landon Etchen really pioneered a lot of this work. He just left my laboratory this week, actually, to go back to the clinic. But I really have a talented team. We really actually have a talented group. Our extensive group of collaborators, our funding sources. And lastly, I'd like to say we are looking for more talented people in our lab. So if you're interested in a postdoctoral fellowship, please contact me. Thank you.